Hi, in this pre-conference video, I really want to just go over some basics of thyroid physiology, thyroid feedback loops, and thyroid laboratory tests. I really want to focus the course material on day one and day two to really clinical management of Hashimoto's. I don't want to spend too much time on reviewing the basics of thyroid function outside of this video and some of the pre-conference material that you have in your course materials. So the key thing is when we're looking at the thyroid, the basic concept is the thyroid is really involved with the basic metabolic rate, and there's a negative feedback loop, right? So the basic concept is the hypothalamus releases thyroid releasing hormone, and then thyroid releasing hormone release is really determined by a negative feedback loop between the circulating amounts of T3 and T4. So the thyroid gland is going to get stimulation by TSH. TRH is then going to be released from the hypothalamic pathways to activate pituitary release of TSH. The TSH then activates the production of thyroid hormones. Then you get T3 and T4 released in the system, and then T3 and T4 impact this negative feedback loop. So what this diagram is really illustrating is when T3 and T4 concentrations are low, that those T3 and T4 circulating levels are recognized by different nuclei in the hypothalamus, and then the hypothalamus releases TRH, which then triggers TSH release. And here you can see the different nuclei in the hypothalamus stimulating TRH release to activate the pituitary. Pituitary releases TSH. TSH activates the basic thyroid hormones, and then the thyroid follicles are busy producing T3 and T4, and then T4 and T3 are released into the tissue. And then T3 and T4 impact the basic metabolic rate and impact general energy production and metabolism throughout the body. And then there's a negative feedback loop between circulating T3 and T4 in this basic pathway. It's just the basics. I don't mean to bore you, but I do want to go into a little bit more detail and go into some laboratory tests. One of the great papers that are in your pre-conference material is a paper titled Thyroid Hormone Regulation of Metabolism. And, one of the things that I think it's important to clarify and I'd like to go through in this slide is when they say that thyroids impact the metabolic rate, what does that really mean? What does the thyroid really do? How does it impact all these systems? And it's important for you to really understand this so you understand the clinical mechanisms of hypothyroidism when it walks into your office, or hyperthyroidism that walks into your office, and how diverse these symptoms can be. So this is a really great illustration of what we refer to as basic metabolic rate and what's actually happening. So we can go through this in order really quickly. And if you get a chance to read the paper does a really great review of each of these mechanisms and explains this process really well. I'm just going to summarize the concepts to you and then jump into how to look at the basics of laboratory testing, and then I'll go over some laboratory examples so you can get used to actually seeing what they look like in a clinical setting for all the different common patterns that you may see with thyroid metabolism dysfunctions. So right here you see the different red nuclei, PBN for example. This is a parvoalbumin nuclear receptor in the hypothalamus, and one of the things that this pathway will do is that the hypothalamic pathways are influenced by T3, and these hypothalamic pathways involving this parvoalbumin nuclei are involved with causing the liver to produce albumin. Albumin is important for supporting osmotic pressure in the serum and in blood, and albumin synthesized in the liver. So this pathway with T3 hormones activates liver production of albumin and osmotic pressure. And there's also different responses with this hypothalamic PBN pathway, where we have control of heart rate, blood pressure, body temperature. You can see that core body temperature is influenced by this hypothalamic pathway, and it's also really important for just your general heart rate. So when people are hypothyroid and they're not getting enough T3 activation of this hypothalamic center, then what happens is in hypothyroid states, low thyroid function states, people come in, their blood pressure is really low, their heart rate's really low, they're really, really cold, and those are pretty typical to see. Now in a hyperactive state, they're going to come in and they're going to have maybe higher than normal blood pressure, their heart rate can be extremely high, and and those are important. The other key thing is when this hypothalamic pathway is not being activated by T3 and there isn't enough albumin synthesis, one of the things that can happen is that can change osmotic pressure, and then you can have swelling in the legs. So some hypothyroid patients have swelling in the arms, swelling in the legs. They end up with carpal tunnel syndromes. They end up with swollen legs. Sometimes their face gets swollen, and a lot of that has to do with this albumin-controlled mechanism through these hypothalamic pathways. Now, if we look at this B section, where we look at the general functions of metabolic rate, this is PVN, stands for paraventricular nuclei. It's in the hypothalamus again. And what you're seeing here is there's an influence on TRH in the hypothalamus. The PVN is in the hypothalamus. And then there's a signaling pathway with STAT3P, and you can see leptin stimulates this STAT3P pathway in this PVN nuclei of the hypothalamus. And body fat releases leptin. So adipose tissue is a very active cell that does more than just store energy. It actually produces leptin, which then controls appetite and regulation of energetics. So one of the things that we know that can take place is that if leptin is released, the STAT3P pathway gets stimulated, and there is an increase in TRH release, thyroid-tropin releasing hormone, to activate the pituitary to put out TSH. But then circulating levels of T3, here you can see T4 converted to T3. This is D2. D2 is the enzyme deiodinase, 5-deiodinase. And this D2 deiodinase enzyme is involved with converting T4 to T3, and then circulating T3 levels have an impact on this MCT8, which is a monocarboxylic transporter protein 8 protein, which then can decrease TRH release. So there is leptin, which stimulates the TRH response, and there's circulating T3s that's modulated, and this is the basic aspects of hypothyroid control from body fat to the hypothalamus. That's part of so-called metabolism, metabolic rate. Here you can see another pathway here, C. This is the ventromedial hypothalamus, and one of the key things that T3 hormones do is that it increases fatty acid synthesis, and as it increases fatty acid synthesis, cyclic AMP pathways, which is normally involved with producing fatty acid synthesis, gets activated, and then you can start to get fuel from body fat. And then what you see in this diagram here is that there's two types of body fat. There's brown adipose tissue they have here as BAT, and then a white adipose tissue that they have here. Brown adipose tissue has more mitochondria, more iron. It's really involved with more thermogenesis. So T3 and thyroid hormones, they activate the sympathetic nervous system, and there are sympathetic fibers in that actually process and burn body fat through androgenic receptors, which then impact thermogenesis and reduce body weight. So when people are hyperactive, they start to really get this brown adipose tissue broken down, and they get really, really hot. So people that are hyperthyroid, overactive, they'll come in like t-shirts, they're just burning up all the time. They'll ask you to turn their AC on. But hypothyroid, underactive patients, they can't activate this B3 androgenic receptor because they don't have enough T3 to stimulate that. They can't break down their brown adipose tissue to produce body heat. This is one of the main mechanisms why people that are hypothyroid are always cold or always hot, depending on if they're low, underactive, or overactive. Now, that's different than white adipose tissue. White adipose tissue is really more used for energy, whereas brown adipose tissue is really more involved with modulating thermogenesis and control. But thyroid hormones, T3, also activates the androgenic receptors. You can see B1, B2AR. This is an androgenic or sympathetic response receptor to burn body fat, to then involve lipolysis, the breakdown of body fat. So this is one of the main mechanisms why people that are hypothyroid have a hard time burning body fat, because they can't activate the breakdown of body fat. This is why they're cold. So these are key essential pathways to understand. Now, as we go from A, B, C, D, E into F here, this is a pathway showing that thyroid hormones, and specifically T3, are involved with converting cholesterol to bile acids. And one of the things that we'll go over in the course, but one of the things you'll see with lab work, when people are in a hypothyroid state and they don't have enough T3, They can have very, very high cholesterol levels and triglyceride levels, and they can't metabolize these fats in their system, and they can't produce bile salts, bile acids. Many people in long-term hypothyroid develop gallstones because they lose the ability to convert cholesterol with bile acids to produce bile. So you'll see that all the time in clinical practice. And then one of the key things that this diagram is showing you is that T3 is essential for converting cholesterol and fatty acids for just normal bioenergetics, but also cholesterol into the production of bile acids. And bile acids bind to bile acid receptors. Here you can see TGR5 and TGR5 up here, and TGR5 are modulators that are involved with gastrointestinal function, autonomic function, and that plays a significant role. So a long-term hypothyroid patient that has really, really high cholesterol and has gallstone issues and can't digest any fats, this whole system is pretty much shut down with them. And then the other key thing you see here with G are the thyroid hormones activate muscle fibers and different energetic pathways in muscle fibers, and this is a really good window for us to look at a patient's physiological state when we get into the thyroid physical exam. One of the best ways to determine if someone is hyperactive or hypoactive is just to look at their deep tendon reflexes. Hypothyroid patients typically have very impaired 1+ deep tendon reflex response, and hyperactive people have like a 3+ hyper response because of the influence of thyroid hormones. So thyroid hormones have an impact in fast twitch and slow twitch, mitochondrial activation, and how sensitive they are to contraction. And you'll see changes with patients that are in an abnormal thyroid state in their muscle fibers. One of the things they used to do in the past was they used to measure Achilles reflex times to determine if someone was hyper or hypo, and hypothyroid patients had a slowly measured Achilles reflex time, and hyper had a very fast Achilles reflex time. That's related to how T3 impacts these bioenergetic pathways in muscles. A major clinical feature of patients that have hypothyroidism is they just have no muscle endurance, and part of the reason is because T3 is so important to make ATP in the actual muscle tissue fibers. So a common thing that hypothyroid patients will say is like they used to go to the gym and be able to work out, and now they can't, or they used to do 10 bicep curls and now they can only do 4, or just walking is exhausting for them. Part of the reason that's happening is because of this direct influence of how muscles in the body need T3 to activate their ATP production. And then finally, as we get into H, you can see the thyroid hormones are involved with the development of B cells, beta cells, in the pancreas to release insulin, and the insulin release as glucose levels go up is activated by T3. So many patients that are in a hypothyroid state tend to have really delayed responses of releasing glucose to insulin. So they get really tired after they eat. They get blood sugar dysregulation. We're going to go into that with much more detail in the course, but this is part of the pathophysiology. So when people say like thyroid hormones control metabolic rate, this is what, or metabolic activity, or basal metabolic regulation, this is a really good diagram that the authors of this paper have put together, and you may really want to check out this paper in your course review. But this explains many of the symptoms that we see in clinical practice with patients that are either underactive or overactive with thyroid function. Now, let's go into laboratory test and just the basic concepts of how this works. So when you're looking at the thyroid function, I mean, the pituitary is releasing TSH, as everyone knows, and as the thyroid gland loses its follicular thyrocytes because they're being destroyed, then TSH levels go up as an attempt to try to stimulate the thyroid gland to produce thyroid hormones. So the most important marker to determine if a person is actually in a hypothyroid state where the thyroid gland is not producing adequate amounts of thyroid hormones to control a normal feedback loop is TSH. And if the TSH levels are high, then the patient's hypothyroid, and if the TSH levels are normal, then the person isn't hypothyroid. And one of the key things to understand is that the autoimmune response can take place and destroy thyroid follicular cells over many, many years before TSH levels actually go up. You have to have a significant amount of follicular site destruction within the thyroid gland to actually have this elevation of TSH. But while the thyroid gland is being destroyed, you can have patients that have every single thyroid symptom. So the key thing about this diagram is a very important concept. When the thyroid gland is synthesizing T4 and T3, the majority of what the thyroid gland puts out is T4. And only about 10%, actually it's less than 10%, is T3. So the thyroid gland is producing this T4 to T3 ratio of 90 to 10%. T4 is not the main thyroid hormone. If you look at this diagram here, you can really see it's T3, T3, T3 that's really impacting these metabolic activities within the cells and within the tissues and turning on all these different receptor site expressions. So the thyroid gland itself is really producing some T3 but a lot of T4, and this T4 has to be converted in tissues. And then the other key thing to remember is that these hormones produced by the thyroid gland are also bound to proteins. They're bound to things like thyroid binding globulin and albumin. We'll talk about that in a slide here. But the key thing is that the thyroid gland is producing protein-bound thyroid hormones, and predominantly T4. And it's this T4 production, an actual protein-bound T4, not free T4, but protein-bound T4, that controls the negative feedback loop with TSH. So when the protein-bound T4 levels are low, that's really what triggers the hypothalamic pathways to activate TRH to stimulate TSH production. So that's an important clinical concept. Now, once the thyroid gland produces T4, there are different 5-deiodinase enzymes found in different tissues. There's 5-deiodinase enzymes found in the brain and in the liver and skeletal muscle and tissues throughout the body. And what they'll do is they'll convert T4 to T3, and then that's part of modulating metabolism. And this is in a way so that the body can use T3 at the rate, at the speed, at the level that it needs to. It's kind of a check system. The thyroid gland will put out all this precursor T4, and then in surrounding tissues, as the body needs to activate metabolism, it'll convert it to T3. But there's different rates of T4 to T3 conversion at different tissues at different times, and the 5-deiodinase enzyme in those tissues determine how much conversion and how rapid and how fast that tissue takes place. All the thyroid gland does is really produce this precursor T4, or at least not all, but majority of the thyroid gland produces is this protein-bound T4, and then the peripheral tissue metabolism determines this T3 conversion. Now, if you look at this diagram, one of the things to understand is the hormones that are produced, T4 and T3 from the thyroid gland, and even the thyroid hormones that are converted from T4 to T3 are all bound to a protein. The main protein is thyroid binding globulin. And when those thyroid hormones are bound to a protein, they can't bind to a receptor. So thyroid receptors can only fit free T3, free T4 hormones, and T3 and T4 have metabolic activity, T3 being the most significant one, but only free thyroid hormones can bind to the receptor site. So the T3 produced by the thyroid gland, the T4 produced by the thyroid gland, T4 that gets converted to T3 are all protein bound, and then at some point those protein bound levels become free. So when you're looking at the ratios, you can take a look at here. These are the percentage of values of bound to unbound thyroid hormones. So 70% of thyroid hormones are bound to thyroxine binding globulin, TBG. There's 10 to 15% that are bounded to transthyretin or thyroxine binding prealbumin, 15 to 20% to prealbumin, and then less than 1% free T3 and T4. That's one of the key things here. So we're looking at around a 0.3, 0.6, very, very little amount of free T3. Most of the thyroid hormones are protein bound. And that's important because certain medications can change these thyroid binding globulin levels and have an impact on the thyroid unrelated to thyroid dysfunctions. We'll talk about that more when we talk about medication influences. So the big picture is this. Thyroid gland gets stimulated by the TSH from the pituitary. Thyroid stimulating hormone activates the thyrocytes and turns on TPO, and thyroid globulin gets converted to T3 and T4. And the majority of the thyroid hormones produced are T4, and then T4 that's measured here is protein-bound T4. Now on labs, they're going to refer to this T4 as total T4. But remember, a very small percentage of thyroid hormones are actually free. So when they say total, that's pretty much 99% or more it's really protein bound. So when you see the word total T4, total T3, you're pretty much seeing protein bound levels. So the total T4 is the key factor in controlling TSH through a negative feedback loop. T3 doesn't have that much of an influence. And then the free levels, since they're less than 1%, they have very little influence on impacting TSH. So you could have people that have a hard time breaking off their thyroid binding globulin to a free state, so they can have less effect on their tissues but not actually be hypothyroid. That's one of the things that, for example, takes place with birth control pills or estrogens for some females. Estrogens increase TBG levels. They can't get their levels into a free state. Their free levels of lab test are very low, but their total T4 and TSH are totally fine. So what you're seeing in this diagram is this T4 and is the T4 levels being converted to T3, and then at some point these protein-bound T3 levels become free, and no one really knows why. And no one actually knows the actual enzymes and steps that are involved with that at this point, but they know that at some point T3 levels get converted to a free T3 state, and it's only this free T3 state that can actually bind to the receptors and then lead to a proteomic response where you get secondary cellular messenger responses that then control metabolic activity through various pathways in the body, to various tissues and various biochemical steps, which we talk about in the other pre-conference video. So these are all the steps that are involved in basic thyroid function. Now, one of the things that we have to discuss as we talk about Hashimoto's and what makes Hashimoto's very unique is that not only is the thyroid gland destroyed, but there's certain metabolic defects that take place that make it very troubling for Hashimoto's patients to normalize their metabolism and to reduce their thyroid symptoms. So this is a paper in your course material. It's called Beyond Low Plasma T3, Local Thyroid Hormone Metabolism during Inflammation and Infection. And Hashimoto's is a systemic inflammatory disease where many of these mechanisms take place. And there's really three main spots of this thyroid pathway that make Hashimoto's so unique. First, number one, there's the autoimmune response against TPO and thyroglobulin, which causes inflammation and thyroid gland destruction. And as TPO and thyroglobulin get destroyed, the surrounding thyrocyte gets destroyed, and there's decreased production of thyroid hormones. And if this level drops, that's when a person goes from being Hashimoto's autoimmune reactivity to actually being hypothyroid. So if enough of these glands get destroyed and the total T4 levels drop, then the TSH goes up and then they could go into a hypothyroid state. Now, another key thing to understand about this pathway is this conversion of T4 to T3, because remember 90% or more of what the thyroid gland makes is T4. That conversion into T3 takes place by this enzyme called 5-deiodinase. And the inflammatory response of autoimmunity can suppress this pathway. So you can't have people where their total T4 levels and TSH are normal, but their T3 levels are low. This is what some people call a T3 syndrome or a low T3 pattern. And those people will be missed if you just measure TSH. So they can make T4, they just can't convert it to T3. But remember, the main feedback loop pathway with TSH is total T4. So the chronic systemic autoimmunity can have an impact here. This is why there's many thyroid patients that feel better with bioidenticals. And it may not be the bioidentical, it's just the fact that all bioidenticals have some T3 in there, and if they can't convert T4 to T3 because of their systemic autoimmune inflammatory response, they tend to, in some cases, feel better when they have some T3 that bypasses the suppression from the inflammatory reaction. Now, more importantly, the inflammatory response also has a significant impact on how the thyroid receptor sites respond. And I'll show you many papers on this in the course, but chronic inflammation makes these thyroid receptors inefficient. So one of the key things that we have to do in a clinical model when patients have Hashimoto's is to really dampen their autoimmunity so their inflammatory load calms down. And as their inflammatory autoimmune reactivity calms down, we can get less progression of destruction in the thyroid gland. We can calm down some of that suppression of this 5-deadenase enzyme, which is so essential to converting T4 and T3, and the thyroid receptor site can also become much, much more efficient in doing its job. Now let me show you some lab test examples, how this applies into a real setting. So here you have TSH, T4, that's your protein-bound T4. Now you have to assume when you look at lab test, if it says total thyroxine or just thyroxine or total T3 or total or just triiodothyronine, that those are protein bound. Unless it says the word free, then you know that it's a protein bound level. So in this scenario, what we see here is the thyroxine levels are normal. T3 uptake is inversely related, by the way, to the amount of thyroid binding globulin levels there are. So if there's lots of thyroid binding activity, then there's an inverse effect on T3 uptake. P-thyroxine index is a calculation that they do for measuring free T3, but it's not very reliable. And here you have triiodothyronine, which is T3. So this is a basic thyroid panel, and what you see is the patient is making T4 at 7. The range is 4.5 to 12, so it's it's within normal ranges. And then the T3 levels are within the normal ranges here. We can be more critical and talk about a functional range, but as far as lab is concerned, these are within normal ranges. But the TSH is high, so this lets us know the thyroid gland is not functioning, that the pituitary has to have increased release of TSH to make the thyroid gland produce regular thyroid hormones, so there's something wrong with the thyroid gland. So that's your classical hypothyroidism. It's Hashimoto, and then if the antibodies were positive, we can then confirm that it's Hashimoto's hypothyroidism. So if either TPO or thyroglobulin antibodies were positive, then we would have a Hashimoto's hypothyroidism. Now, take a look at this example. In this scenario, we actually see that the TPO and thyroglobulin antibodies were positive. That's Hashimoto's. But if we look at the TSH level, the TSH level is within the normal reference range. So this person can't be diagnosed hypothyroid. This is a Hashimoto's autoimmune reactivity, or they call it silent Hashimoto's. But the person is having some significant inflammation in the thyroid gland. And I can tell you, if they're having significant inflammation in the thyroid gland, they have an autoimmune response, they probably have systemic inflammation in their body, and they could have any of these pathways also involved. Now, we can look at their T4 levels and look at their lab T3 levels and their free levels. They're all within normal reference ranges, meaning that the body can compensate. Despite the fact the thyroid gland is getting destroyed, there's still enough thyroid hormones being produced in the body. The body can convert T4 to T3, and there are free levels of T3 that are adequate. So this is your classical Hashimoto's pattern that hasn't progressed to hypothyroid, but this patient can walk into your office and have every single thyroid symptom. And it's just a matter of time where there's enough damage to the thyrocytes from this autoimmunity that you see here where they actually will become hypothyroid. So this is a autoimmune, Hashimoto's autoimmune reactivity, but it's not Hashimoto's hypothyroidism yet. So that's one thing to be aware of. Now, if you look at this one, this is a person where their TSH levels are really low. And this is a typical thing that you will, with their total T4 thyroxine levels and T3 levels are within normal reference range. And in this scenario, this is a common thing you'll see with patients that are on replacement. As soon as they go on replacement, their TSH levels become suppressed. So if you ever see a panel like this, first question you need to ask is, were you on thyroid replacement when you had your blood test done? And if they say yes, that would explain this pattern. And sometimes you'll see this with people that have significant inflammatory response. The inflammatory response can also suppress TSH. And also with some patients that have Hashimoto's, what will happen is their tissue gets destroyed and there's a little bit of T4 that gets into circulation, and it starts to, the T4 that gets into circulation starts to suppress the negative feedback loop, but it's not outside the lab range, but it'll be in the high end of the lab range. So like here, the T4 is 10.7, maybe, right before the blood draw was like in the 12, 13 range, but just high enough for them where there's some negative feedback loop suppression. And if they're not on replacement, you saw this, you definitely want to check TPO and thyroglobulin to make sure that there's no autoimmune reactivity taking place there. Here's another example. This is your classical low T3 pattern. So the TSH is normal, they're producing T4, they just can't convert it to T3. So this would be a defect right here. They can't convert T4 to T3. And for many people, the inflammatory response for autoimmunity can do that as well. So whether it's Hashimoto's or another autoimmune disease or another chronic inflammatory condition, inflammation has a suppressive effect on the 5-deiodinase enzyme that converts T4 to T3. So this is a T3 pattern. Here you can see a pattern where everything is suppressed. TSH is low, so they're not producing T4, and they're not producing T3. And this is a pattern that is related to this entire pituitary being suppressed. So it's not hypothyroidism, it's actually a primary hypopituitarism. TSH is low, so T4 is low and T3 is low. And there are certain medications that can do that, and significant inflammation, really acute inflammation, especially after trauma or surgery, has this potential to cause a significant pituitary suppressive pattern. We're going to go over these in more detail in the course, but I just want you to kind of get a taste of this before we jump deep into it. And here we can see another lab test. This is a little more thorough of a thyroid panel. Ideally you want to have a thyroid panel that has everything in it, but in a realistic clinical scenario, patients are coming in with files, and you have to look at what lab tests they have. So you may not have every single thyroid marker done. And then also patients have budgets, and you can't sometimes spend hundreds and hundreds of dollars on a lab test, so you have to choose and pick which markers you can evaluate. This is a great sample because there's a very thorough thyroid profile that's done here. So here right off the bat you can see TSH is high. So TSH being outside the lab range confirms that pituitary is overworking, that it's trying to get the thyroid gland to work. So they're actually hypothyroid. Here you can see the TPO enzyme positive, so that confirms that we have a Hashimoto's hypothyroidism that's taking place. And then in their hypothyroid state, they can produce some T4, they can produce T3. They're just having to have the pituitary put out more TSH to do it. There's an autoimmune response. Now this is thyroxine binding globulin. This is what determines how much binding globulin a person has, and this person had a level of 29, so they're getting close to having so much binding that their free levels may eventually drop at some point. At this point, their free T4 is on the normal range, but right on the borderline, but their free T3 is right in the middle or lower end of the range. So they don't have any issues with free production, but since their thyroid binding globulin levels are pretty high, then there's some possibilities there. So that's kind of the real life example of this diagram. A lot of times people will see a diagram like this and go, yeah, I know it, I understand it, this is so basic, it's so much review. And then the minute they see actual lab tests, they have no idea what to do. They totally freeze up. So what I'm trying to hopefully do in this pre-conference video is to make sure that this image of these pathways translates to actual lab tests and how they look like. And that's one of the biggest things that I've seen as an educator working with practitioners to teach them how to really understand and evaluate thyroid function. So if you get a chance, just really make sure you understand this concept here one more time. The thyroid gland is the area of destruction with Hashimoto's. When you look at normal thyroid function, TSH levels come in to stimulate the thyroid gland, and but the thyroid gland mostly produces a T4. This T4 has to be converted to T3. This T4 to T3 conversion takes place in peripheral tissue. At some point, the T3 levels and even the T4 levels have to become free, T3 and T4, and then those free T3 and T4 levels actually bind to receptors and have a tissue effect. What makes Hashimoto so unique is that there's destruction in the thyroid gland, which then causes hypothyroidism. There's some conversion of T4 to T3 issues from the inflammatory response downregulating this 5-deiodinase enzyme. And the chronic inflammation of autoimmunity can also make the thyroid receptor sites not respond very well, despite having replacement in thyroid TSH levels that become normalized with replacement. And if you take a look at this diagram and you can look at all the examples, you can clearly see which areas are dysfunctioning. We'll go over this in much more detail, but I just wanted you to have some basic review as we get into the course. Thank you for your attention. I hope this video helped.